Good morning. First case is a 6-year-old male, status post fall, right hand dominant, found to have a right metatarsal proximal humerus fracture. They were neurovascularly intact. They were given a sling. Next case, 57-year-old female, status post fall. She was right hand dominant. She was found to have a left distal radius fracture. She was closed reduced and placed in a sugar tongue splint. Yes.
Is anyone able to see the PowerPoint slides?
Yeah, I can see the slides.
I see them. I see the wrist.
Thank you.
We will continue. Next case, 43-year-old male, status post fall. He had a non-displaced right medial mal ankle fracture. He was placed in a short AO splint. Next case is a 15-year-old male, also a trip and fall during a basketball game. He had a minimally displaced right medial mal ankle fracture. His distal tibia physes appear closed. He was placed in a short leg cast bivalve.
Are you gonna have them weight bear or?
Non-weight bearing for at least 2 to 4 weeks, I believe.
When will you see him back?
Can you repeat that?
When will you see him back?
I'd have them follow in the office in about a week.
Follow that closely. High risk of that displacing.
Did you check anything else on that ankle?
We got proximal X-rays of the fibula as well to rule out a Mason Oob.
Any stress view or anything?
I believe we had a gravity stress view as well at the ED acquired. Yeah. Oh. Thank you.
Morning. First case is a 2 + 8-year-old female, status post fall at a trampoline park. A right proximal tibia fracture. She was neurovascularly intact and placed into a long leg bivalve cast. This is a 57-year-old female, status post fall with a trimalleolar equivalent ankle fracture with a small posterior malpiece. She was neurovascularly intact and placed into a short AO splint. This is a 58-year-old female, status post fall with a right Weber-B ankle fracture. Stress view was negative. She was made weight bearing as tolerated in a cam boot. This is a 26-year-old female, status post fall with a right medial mal fracture, minimally displaced. There was no proximal fibula fracture. She was neurovascularly intact and made non-weight bearing in a short AO splint. We'll similarly follow this one closely. This is a 63-year-old female, status post fall down the stairs with a left fifth metacarpal shaft fracture. On evaluation in the office, she had a significant rotational deformity. So she was taken to the OR for a left fifth metacarpal ORIF, the retrograde intramedullary screw.
Is a intramedullary device the best type of fixation for something with rotational deformity?
I think it's reasonable for something with a rotational deformity if you're able to correct it and get good fixation. The problem with this fracture pattern is it's kind of like a long spiral oblique. So perhaps you know, a lag screw and a plate might have been a little better, but we were comfortable with the fixation we had after we got the screw in and the rotational deformity was corrected.
So you still have on one view malalignment, and you have a
Yeah.
huge spiral long oblique fracture.
Yeah.
Why not reduce it anatomically? And either if you want to put screws in, put 2 or 3 screws in,
Right.
which is standard treatment for a rotational deformity, or K-wires or any type of standard fixation. Intramedullary fixation is the worst type if you have a rotational problem. If this wasn't rotationally unstable, you wouldn't even need to operate on it. So I can understand for a transverse fracture, but I don't, this doesn't make any sense.
Yeah, we certainly had those discussions. We talked about interfragmentary screws as well as K-wires, but
Wouldn't it even be easier just to put, I mean, if you love screws, to just put 3 regular lag screws in?
yeah, that was certainly an option.
You know, Jeremy, I think this one is okay in terms of the technique, because I think you do get some diaphyseal kind of contact. So I think there is some rotatory holding there, if you will. I don't think it's as unstable as Dave said, but the issue I have is when you look back at your initial x-rays, you put that screw pretty low. Like, I just worry how much of that distal fragment you're capturing with the head of that screw.
Yeah,
You know,
that's a fair point. We
You're
did,
right
yeah,
you're right at the neck, and you've recessed that screw so far that I'm concerned you don't have good distal capture on that fracture fragment.
yeah, we did bury it pretty far. I see your point there.
Hey, Brian, there's no diaphyseal fixation here. It's smooth. I mean, there's no, unless you did it like a tibia or a femur. I mean, maybe it's a great intramedullary fit, but this isn't like a tibia or a femur. You have one screw size, right? The diameter of that shaft is the same no matter what metacarpal you put it in. It doesn't come in 4 millimeter, 5 millimeter, 6 millimeter. It comes in one size. You're relying on the threads proximally and distally. You have no distal diaphyseal fixation, and maybe in an older person, it's great. And like you said, proximally, you have almost no fixation. So this is not what, this is not, I think, a standard way to fix it. I don't think that should be the teaching. And I agree with the other point that it's dorsal.
Are you going to move the patient right away, Jeremy?
So we were going to keep him in the splint for about a week until the sutures came out and then start motion. This is a 61-year-old male, status post-fall with a right distal humerus fracture. Patient was neurovascularly intact. Of note, the patient had a prior radial head replacement in an outside hospital for an injury suffered mountain biking 5 years prior. Unfortunately, for some reason, I didn't have access to the fluoro, so I only have the post-ops. We did a distal humerus ORIF with parallel plating. We did an olecranon osteotomy. Our initial plan was to address the radial head, but once we got in there, it was found to be stable. So we left it alone.
Some of your screws are a little long there, Jeremy.
Yeah, it's tough to say. On the x-rays, they do look a little long. On the fluoros, they looked okay, and we felt we had direct visualization, medial and lateral, and none of the screws were poking out, so we felt comfortable leaving them.
Yeah, because they're volar, you probably couldn't see them from the back, but they definitely look long, and it'd probably be okay. But you always take these patients through a full range of motion after surgery. Make sure you don't feel any crepitus.
Yeah.
What else did he have besides the radial head and the initial films?
Say that again?
What is that? What is the button?
Yeah, the button
Their
was, we
dorsal
thought was for probably like a coronoid fracture. We took the button out.
You know, Jeremy, just looking at your bottom right picture where the radial implant, the stem is going in, I'm a little concerned that there's a fracture line that goes at the level of the radial neck. You can see there's a lot of osteolysis around your implant, and then
Yeah.
I'd be concerned that there potentially be a fracture through there. So just something to keep an eye on. You know, the other option is, could you have even pulled this radial head implant out?
Yeah, we had all those discussions in the OR, and we were ranging the elbow, and with pronation and supination, the radial head was well fixed and moving appropriately. So we decided to just leave it.
Agree with that.
This is a 51-year-old male, status post fall, from a train platform with this left proximal humerus fracture with a significantly displaced greater tuberosity fragment. It was neurovascularly intact, taken for a proximal humerus ORIF.
Anything else broken besides the tuberosity?
Yes, there's a surgical neck fracture, but it's minimally displaced here. I'm not sure that I would qualify it as like a full part.
Can you see? You could see it on the pre-op films.
Yes.
Why not make those screws a little longer?
Yeah, I agree they're a little short, but we felt we had good purchase in them, and we certainly didn't want to go along with them. And we felt that the greater tuberosity fragment was well fixed.
How old is the person?
51.
Because how do those screws work?
By engaging, distally.
They're not bicortical, right?
They're not bicortical.
So they're just kind of sticking in bone, and the best bone in the humerus, even a 51-year-old, is subchondral essentially.
Right.
So I don't know if you have a lot of fixation of the actual head fragment.
But I think at a 51-year-old non-displaced, I think that's fine. I mean, you're trying to avoid the biggest complication, which is what, Jeremy? Most common.
Screw cut out.
Yeah, cut penetration. So I think it'll be all right.
Good morning. First patient is an 8-year-old female sustained a fall doing a cartwheel, presented 1 day after this injury with a right radial neck fracture. She was neurovascularly intact and closed reduced, placed in a posterior splint. Next patient is a 17-year-old male, punched the TV, sustained this left small finger metacarpal shaft fracture. Patient was neurovascularly intact, closed reduced, and placed an AP slab splint. Next patient is an 89-year-old male, sustained a ground level fall, was found to have a right non-displaced hip intertrochanteric fracture that was picked up on MRI. Patient had significant cardiac comorbidities and was basically had contraindications to undergoing surgical management of this injury, so he will undergo non-operative management.
What type of
Which is what?
anesthesia? What type of anesthesia did you use to get that perfect metacarpal reduction?
For the metacarpal, I just did a local hematoma block.
That's a great job.
And what were you said contraindications to fixing the intertrope?
Yeah, so the patient had significant cardiac history, multiple CABG procedures, severe aortic stenosis, reduced ejection fraction. So in order for him to even, consider surgical management, he would need a TAVR, which the patient, was not interested in. The patient was also refusing any surgical intervention for this fracture as well.
Was he ambulatory before this?
He was
Did he walk
ambulatory.
at all?
Yes, yeah.
As long as you have a big discussion with him.
Yeah, we had
he's
lengthy
already been up and-
discussions.
I believe he's already been up and walking around with the fracture as well. So he's mobilizing.
Dan, can
Thank
you
you.
go back to that radial neck? So what, when you had them sedated for the closed reduction, what was the range of motion after your reduction?
Yeah, so after reduction, patient had near full range of motion. I compared it to the contralateral side. A little bit short in full pronation, but probably like less than 5 degrees of a difference.
So that's probably the most important thing. It's nice when you have them sedated. It's tough to get an exam when they're in the office if they just show up to the office like this. So what would you do if they come to the office a week later and they're back to their pre-reduction? Go back a slide. Say they're like that in the office and you're splint when they come in a week.
Yeah, so so on initial films, it's measured out to about anywhere from like 45 to 50 degrees of angulation. So I know the recommendation is, after a closed reduction, if it's still, unacceptable. So if it's still greater than 45 degrees, then we definitely need to consider surgical fixation. So if it goes back to this, then at that point, I would consider either, using like a joystick technique or a metazo technique using some K wires, or if we need to do an open reduction on internal fixation.
Yeah, I agree. It's probably a little bit too much just to leave alone. At the very least, you want to make sure that they have their motion. And if it already failed a closed reduction, you're going to the OR, to examine them. You can still consider a closed reduction, but probably should put something in there if you're going to the OR and it already lost a reduction. So this is probably one you'd probably try to joystick if you can't get it closed, or, do it percutaneous, but hopefully it stays where it is.
Thank you.
Morning. First patient is a 14-year-old male who fell on a sidewalk and sustained his right hand, fourth and fifth metacarpal shaft fractures. He was neurovascularly intact. He was closed reduced and placed into AP slabs. Next patient is an 85-year-old gentleman with a history of diabetes.
What are you going to do with that
dementia.
one?
I'm sorry, what was that?
What are you going to do with that one? That
Metacarpals.
Yeah.
I would just watch this and try to treat it non-operatively. I think the reduction is adequate. Just get new x-rays in about a week, see it, and make sure that the alignment is maintained. Probably just cast it for a couple more weeks and then get him out of it and try to move it.
On the middle image on your oblique, it looks like the fourth is not even touching the shaft. I don't know if that's adequate, unless that's a projection, because it looks like the fourth, there's no contact of the shaft.
I think there's actually one more oblique that we have where it looks like there's still some bony contact.
I agree with that last comment. The middle x-ray shows that the fourth isn't touching at all on that oblique view. The fourth shaft is completely overlapped with the fifth, and there's nothing proximal to it. If there's no contact, I don't think that's acceptable.
Yeah, I think that one's going to be a fixer.
So if you did fix it, what would you do? How would you fix this?
I think because it's pretty transverse, you could actually probably do like an intramedullary nail for this one, or intramedullary screw.
Yeah, or a simple K wire, which costs $3.50.
We get those for $3 1/4, Dave. You're getting screwed.
Just a comment on that, Anna. I think that multiple metacarpal fractures are a relative indication for surgery.
Right.
I think if they were both transverse in the mid-diaphyseal region, then that would be a perfect indication for your intramedullary screws. But I don't think you're going to be able to do an intramedullary screw on the fifth one. I think it's too proximal. So like Dave said, either the K wire's there, or you could also make the argument to go ahead and open this up, plate these fractures, and then get the patient moving right away, versus closed/open reduction, pinning, immobilization, and then range of motion thereafter. I think either of those are acceptable.
People confuse the fact that you can't move early with a simple K wire. There's no contraindication, and the splint should never even include the interphalangeal joint. So no matter what type of fixation you use, motion starts the next day. The question is whether you're starting MP motion, because if the pin comes out at the head, it's sometimes hard to move that. And if you're pretty good, you get the pin to come out dorsally on the wrist, then you can move all three joints right away. So I don't think moving the finger determines what type of fixation you should use.
Next patient is an 85-year-old gentleman with a history of diabetes, CAD, and dementia, although he is ambulatory. He fell and sustained his right femoral neck fracture. He was medically optimized and taken for a right hip hemiarthroplasty.
Good morning. First patient is an 86-year-old female, status post fall with a left cervical femoral neck fracture. I'm on a left hip intramedullary now. Next patient's an 82-year-old male, status post fall with the right hip intertroch fracture. Underwent a right hip intramedullary now. Next patient is a 66-year-old male pedestrian struck with a left hip intertroch fracture. Underwent a left hip IM nail. Next patient is a 74-year-old male, status post fall with a right hip intertroch fracture. Underwent a right hip intramedullary nail. Next patient is a 92-year-old female, status post fall with a left femoral neck fracture. Underwent a left hip hemiarthroplasty cemented. Next patient is a 46-year-old male, status post motor vehicle collision with a right knee dislocation, a lateral femoral condyle fracture. Additionally, this patient had a patellar tendon tear. Underwent a CT scan. Showing this lateral femoral condyle fracture. He had a knee arthrotomy and a very large anterior anterolateral knee arthrotomy as well. He underwent INT, lateral condyle cannulated screw fixation, external fixation of the knee, as well as repair of that patellar tendon.
Hey, John, what's the sensitivity of CT detecting an arthrotomy?
Well, there's some studies that this one for sure wouldn't need that because it was like massive and you could see the entire joint. But in general, they say it's almost 100%. So it's extremely high.
Yeah, if you see air in the joint, it's 100%.
Yeah.
Hey, John,
We
you
saw
tell
the
us-
entire
Get an ABI when you first saw this patient?
Yeah, we did get an ABI. It was it was like above 1. It was like 1.09, I believe. And he got serial ABIs as well. He was initially placed into a knee immobilizer. And we did multiple ABIs when this guy came in and after the external fixation for him.
So what's the plan moving forward? What was the rest of his exam like for his knee, and what's the plan moving forward for what else we think might be involved?
So we got an MRI with Mars after the fact. It's not a great MRI, but it was, it was yeah, terrible. But we could see pretty much everything within the notch. We saw that the ACL was completely torn. The PCL, there may have been about one fiber that was hanging on for dear life. The PLC was out. The LCL was out. MCL was intact. So he's going to need a ligamentous reconstruction at some point. Our plan was, looking like leaving him in this external fixator for about 6 weeks, allowing him to get, relatively stiff at that point. Then we're going to work on the patellar tendon, or then we're going to work on the knee range of motion and kind of do a delayed ligamentous repair reconstruction.
John, why is the patella sitting so distal? 'Cause on your lateral views, it seems like that's the inferior pole is like almost at the level of the top of the tibia. Was he missing any patellar tendon tissue or anything?
He wasn't really missing, he was maybe missing just a little bit of patellar tendon. It needed to be debrided a little bit. So he was definitely missing a little bit of patellar tendon tissue, which, likely is, causing him to have a little patella baja.
He avulsed off of the inferior pole of the patella, I presume.
No, it was actually like kind of like mid substance. It was, it was kind of transected. We were able to get a good suture fixation within the distal and proximal tendon.
What are the ratios, John, to judge patella baja or alto?
Insole Savati ratio. So it's 0.8 and 1.2.
There's one other one, Blackburn Peel as well.
What was that?
There's a second ratio you can do as well called the Blackburn Peel ratio. So look them up and measure it. Let us know.
Okay.
Is there a big open wound?
Yeah, it's a massive open wound. So we fixed the lateral femoral condyle through the arthrotomy.
Did the wound need any reconstruction, or could it be repaired primarily?
No, we were able to close it primarily. We irrigated it and closed it primarily.
So why are you keeping the X fix on for 6 weeks? I know you can't, you have to let the patella tendon heal, but why are you keeping those pins in for so long?
That was our plan to keep the X fix on for 6 weeks, just mainly to protect our bony repair as well as the patellar tendon repair.
I would assume he's grossly unstable after he was grossly unstable with everything out except the MCL.
Yeah, he was extremely unstable. Next patient's 22-year-old male, status post MVC with left posterior wall acetabulum fracture dislocation. I want a CT scan before reduction as well as after the reduction. There was an incarcerated fragment in the joint. He was taken that same day for posterior wall acetabulum ORIF as well as a labral repair.
How did you repair the labrum?
With 2 suture anchors. Next patient's an 84-year-old female, status post fall with bilateral proximal humerus fractures. She was made non-weight bearing in a sling. She was neuro intact bilaterally. See the CT showing the joints were reduced.
So any plans for her?
We had talked due to her being a polytrauma about possibly fixing this left side, possibly with an intramedullary nail. Patient was resistant to undergo any sort of surgical fixation, and we're electing to just watch her for now. This is a 67-year-old male, status post syncopal event with a C7 anterior avulsion fracture. It's an extension type injury, extension teardrop injury. So he's going to be treated non-operatively in a cervical collar for 8 to 12 weeks.
Hey, John, on that posterior wall fracture, I didn't really see, was that a spring plate that you guys used, or was that just a 1/3 tubular plate that you cut and bent?
1/3 tubular plate that we cut and bent.
Okay. It's a lot more affordable. Was there any marginal impaction when you guys got in there?
No.
Morning. First patient's a 25-year-old female, status post MVC with an isolated left distal ulnar shaft fracture. She was placed into a sugar tongue splint, follow-up outpatient. Is a 27-year-old male, status post MVC, an L3 burst fracture. MRI was obtained that shows that it does not go posterior. He's going to be treated with an LSO brace. It's narrow intact. Is a 14-year-old male who fell playing basketball with a left Salter-Harris-Chew distal tibia fracture. He was closed reduced and placed into a long leg bivalve cast.
It's a 23-year-old female status post MVC a few days before she came to us. She was closed reduced, put into a sugar tongue splint. So a 5-year-old female, non-verbal autistic child who has a Salter-Harris 3 distal fibular fracture. She was placed into a short leg cast. So a 67-year-old male, he was a ped struck. He has a Schatzker 3 or Schatzker 2 tibial plateau fracture. He was placed into a knee immobilizer. So 81-year-old female status post mechanical fall. She has a right proximal humerus fracture. She was placed into a sling, made non-weight bearing. Follow-up outpatient. So a 6-year-old female status post fall into her bilateral outstretched hand. She has bilateral distal radius fractures. She was placed into a removable splint on the right and a sugar tongue splint on the left. So 66-year-old female status post being good head struck. She has a non-displaced medial mal fracture. Proximal films were obtained. It was negative for Mason-Oof type injury. She was placed into a short AO, made non-weight bearing. It's a 65-year-old female status post mechanical fall. She has a trimalleolar fracture dislocation. She was taken to the OR the next day for ankle ORIF. 86-year-old female status post mechanical fall with a left non-displaced femoral neck fracture. She was taken the next day for cannulated screw fixation.
Just our upcoming events slide. Morning. First is a 6-year-old male who is on a Ninja Warrior course when he fell. So this left supracondylar humerus fracture. Taken to the OR for an elbow CRPP. Next is a 70-year-old female with a history of severe rheumatoid arthritis on chronic steroids and methotrexate, who fell from a step ladder with his right open distal humerus fracture. CAT scan images were not great. Was taken for an elbow IND and ORF. Next is 22-year-old.
So Andrew, just to go back on that elbow, what was her pre-injury function like? Did she have pain? And what other surgical options do you have here?
So she had a little crepitus in her elbow, but otherwise it's fairly functional. She does not have any other medical comorbidities. She lives independently. One option we had discussed, had it not been a grossly open fracture, would be to do a total elbow.
Would you do an elbow on that, David, Brian?
Well, I missed the part that it's an open fracture, so I don't think I'd put a total elbow in an open fracture. But boy, this thing is comminuted, and I bet her bone is not going to have good purchase on the distal segment. So
Actually,
if I do,
the fixation was actually better than we were expecting it to be, but
yeah,
we definitely had discussed that total elbow. She would be a perfect candidate for it had she not had an open fracture.
I mean, whoever did this is technically excellent, but maybe this is one where, you know, you don't start early range of motion and you accept a little bit of a flexion contracture.
Not only is it excellent, you did it without an osteotomy, which is unbelievable. So this is a great job, and I agree. Slow with the motion because you don't want it to fall apart. Give it every chance. A little stiffness isn't so bad here.
Her major complaint the following day was just that her shoulders felt a little stiff, which is normal for her in the morning, but she moving.
I think with
Any
the
reason not to?
go ahead, Serge.
I was wondering why not put screws across the across from one plate to the other, across the spool, kind of like the principles from O'Driscoll and Morey.
Yeah, so that's obviously the hot topic now, but you know, we got screws as far as we could across. The screws were going to, through the plate, we were going to kind of start aiming into the joint a little bit. So we stopped them a little bit short. You know, I know that's the new literature. I've done it this way for years. I've never had one of these fall apart ever. So, you know, papers can show that it's biomechanically superior. I could put 10 plates in there and show it's superior, but, you know, also whatever's adequate is adequate. And I think this is more than adequate.
What about advantage with the range of motion since you started earlier and it's a little better if you don't have to keep them in a splint for 3 weeks?
And a 70-year-old with rheumatoid, I'm not terribly worried about getting her moving too early and getting her a little bit of a contracture, but I think I'll move this. I'll move her.
If it were not fixable, if it were even more comminuted, what would you do? Would you stage it? And how long would you wait if you wanted to do a total elbow after an open fracture? Or would you just do like a bag of bones? What would you do?
I don't know how long I would wait after an open fracture if I was going to stage it to do a total elbow. I'd have to look up that literature.
You know, there's probably not too much literature on that, but I'd probably wait at least 6 weeks, KG, treat it as a bag of bones and see what happens.
Next is a 22-year-old male who was intoxicated and was involved in MVC, had this left femoral shaft fracture and a right pilon ankle fracture. So he's taken to the OR for a retrograde IM now. And his pilon was taken for a X6. Next is VD. She's a 22-year-old female, was a passenger in MVC with this right tibial shaft fracture, as well as a scapular fracture. She had a previous ankle ORIF. She's taken for a tibia IM now. And then a CT of her scapular fracture. Next was a 38-year-old gentleman who was intoxicated and drove into a pole with his right open calcaneus fracture. It was a Sanders 4. It was significantly comminuted. Took him to the OR for an IND with plans for a primary fusion in the future. Thank you.
Good morning. The first patient is 58-year-old female, status was fall with right proximal tibia fracture. Patient was taken to the OR for right proximal tibia ORIF. Next patient is 66-year-old female, status was fall with right proximal tibia fracture. Patient was taken to the OR for right tibia ORIF. Next patient is 23-year-old male, status was MVC, who came as a trauma with right knee arthrotomy and right bone forearm fracture. He was taken to the OR for right knee IND and wound closure and right bone open reduction and internal fixation. Next patient is 72-year-old male, status was MVC with right femur subtrochanteric fracture with intertrochanteric extension. He was taken to the OR for right femur IM nailing.
What did you guys do for that subtroch in terms of position and fix?
So we did on fracture table, which was not easy because the patient was obese and we got difficulty to get access to the femur, but finally we find out our access point and it was a little bit of struggle. So probably it would be better if we get like lateral position.
So what's the, and you use what kind of nail?
We use a meta nail because the patient's this intertrochanteric extension was exactly in the piriformis fossa. So, you know, at the beginning when we saw the X-ray, we were considering the piriformis nail, but after CAT scan, we decided to go with the meta nail.
And so what kind of deformity did you guys end up with?
You know, it's always risk of the varus deformity of the neck, but
Put the films back up, please.
On your post on the plain films. So what tricks could you use to, if you have to use a graded choke entry to prevent yourself from going into it? Because that's what you expect.
So we should go as much medial as possible, but because of patient's habitus, that was the best entry point we could get. So we accept that. And I don't think we should.
So what other things you could do to help you prevent that? It's more medial starting point. So you're doing what they call trochiformis.
Trochiformis.
Yeah. And then so that's not working for you. What else could you do? I'm assuming you reduced the fracture first before putting the nail.
We reduced. We used collinear clamp and reduced the fracture, and then we put the nail in.
So you opened, made a percutaneous incision, and did the collinear.
Actually, we did the incision for the lag screw, and we put the collinear clamp to this incision. So we didn't do like extra incision on the skin. So the lateral cut on the femur was through the.
Did you have the rod in first if you did the bigger incision for a lag screw?
So we did this incision for lag screw, and we put the collinear clamp to reduce as much as possible. We restore rotation, and we keep it with the collinear clamp. But when we clamp it, you know, this fragment, there's like butterfly fragment now because we clamp it and we squeeze it, and it's broke. So.
Did the nail go in first before we put the collinear clamp on, or did you put the collinear clamp on and then put the nail in?
So we put the collinear clamp when we got the guide pin, and then we try to put the nail.
The nail.
Which one?
The nail will always win, Ajay. You could have it clamped perfectly, but if you've got, same thing with the tibias. You have it clamped perfectly, you don't do all kinds of things, but then once the nail goes down, it's going to make the deformity. It's going to make it'll beat the clamp every time. So what I think they did, Serge, which they just assumed where the lag screws were going to go into the head, make an incision, put a clamp on it, and then they reamed and put the nail down, and then the deformity happened. So the old Russell Taylor classification talked about type 1, type 2, and whether that the extension went into the piriformis fossa is a relative reason not to do a piriformis nail. You can still do a piriformis nail on these people. You just got to be careful. And I think lateral piriformis nail, then you wouldn't have had any of these issues.
Yeah,
with that being said, I think it's going to be fine.
A lot of struggling on the fracture table to get this point. And
you could still do a greater choke nail in a lateral position. You know that, right? It helps you. It just you don't typically do it.
That would be probably better if we put these patients in lateral position. It would be easier to to get, and probably we could get like, piriformis entry point when we got.
Yeah, because you're still going to fight the nail deformity.
Yeah, if someone's obese and you have a subtrope, my preference is always to go lateral. And not so much
I
for
think
the
just
nail, although it
obese,
helps
period.
both.
Anybody who's obese is going to go lateral. It's just too much of a struggle on the fracture table. It's just an unnecessary struggle.
I agree. That was the lesson we learned after this case.
And what about so you don't need traction on these fractures once you put them lateral?
Oh, in the lateral position, probably we don't need it. We can reduce it.
Okay.
You could still get traction either through
It's a hand traction, usually.
appropriate intern, or you could put in a traction abstraction bow and hanging off the side of the table.
Just manually. Okay.
Just manually.
Yeah, manually usually works fine.
Hey, Andre, real quick, your first proximal tibia fracture, your construct, are those all unicortical screws distally?
Yes. So for the least plate, we use all unicortical screws in the first case.
Was there a reason that you didn't go bicortical distally?
Required fixation for that. Patients will be to touch weight bearing if it's non-displaced fracture.
I'm just curious.
The list plate, the screws come only specific sizes, 18, 27, and list doesn't give you increments of 2. Those self-drilling, self-tapping screws can come only a certain size.
Got it.
Yeah, so if you look at the literature, unicortical screws is probably as good as a bicortical regular screw with pull-out strength, but you can get the pararticular set and you can put bicortical screws with this. If you 5/0 bicortical ones, you got to just drill both cortices. And like Andre said, non-displaced fracture. This is just a lot quicker and easier just to put them all unicortical, and you have plenty of fixation.
For sure.
Thank you so much. That's it. Thank you.